Good evening, everyone. Thank you for joining us for tonight's webinar, Clinical Guidelines in Practice, Caring for the Patient with Alopecia Areata, presented by SDPA's Dermcast and supported by AbbVie. I'm Cynthia Griffith, Editor-in-Chief of the Journal of Dermatology for PAs. A little housekeeping first. If you have questions, please submit them in the comments section, and we'll have a live Q&A with the speakers at the end of their presentations. We'll look forward to all of you participating in this interactive discussion. Now I'd like to introduce our speakers. Hayden Middleton is a family practice PA, educator, and researcher who currently works for mHealth Fairview in St. Paul, Minnesota. He also serves as adjunct faculty in the Doctorate of Medical Science program at Augsburg University. He has a special clinical and research interest in dermoscopy, dermatology, procedural medicine, and LGBTQIA+ medicine. He has presented both CME and his research at state, local, national, and international conferences. He is a previous AAPA PAEA research fellow, and he has published multiple peer-reviewed journals over his career. He also serves as the current president of Minnesota Academy of PAs and is the co-chair of its DEI committee. We also have Dr. Arash Mostaghimi, a prominent dermatologist and researcher at Brigham and Women's Health Hospital in Boston, Massachusetts. Dr. Mostaghimi specializes in epidemiology, the patient experience, and treatment of alopecia areata. This presentation tonight is in two parts. The first presentation will discuss the workup and diagnostic approach for the chief complaint of alopecia. These recommendations are from SDPA's Clinical Practice Guidelines on Hair Loss, which was published in the JDPA, and full content is available at jdpa.org. The second part of our presentation tonight will cover the United States treatment guidelines for adults with severe alopecia areata, developed by the Alopecia Areata Foundation and the American Hair Research Society. So thank you so much, both of our speakers, for being with us today. And I'll have you start off, Hayden. Thanks.
Thanks so much, Cynthia. I'm just going to wait for the slides to get brought up there. There we go. All right, so I'm going to be going over kind of dipping our toes into the water as we get introduced to alopecia areata and go over the diagnostic approach for these patients presenting with alopecia, and we'll specifically be digging into alopecia areata labs that are indicated as well. All right, we can go to the next slide here. Next slide. All right, so the learning objectives. First, I want everyone to develop an understanding for appropriate serological and diagnostic workup for a patient that presents with alopecia in general, but also specifically understanding what labs have utility when it comes to alopecia areata. I want everyone to understand the latest available treatment for alopecia areata, which will be covered in the second portion. And overall, hopefully, we're hoping that you leave tonight's presentation with an improved overall ability to care for a patient who presents with alopecia areata to your clinic. Next slide. All right, I don't have any disclosures or financial conflicts for my portion of the lecture. We'll go to the next slide. So first, I think we've all seen a patient with hair loss presenting, and this is very frustrating for patients, and it really accounts for significant healthcare utilization and cost. I know in primary care, we tend to very much overorder when it comes to evaluating patients with alopecia diagnostically. And it can also be a sign of an underlying medical condition that requires attention and treatment. And overall, I think we all know this, hair loss can be divided into scarring and non-scarring hair loss, which is very important to distinguish because it certainly sets the tone for how you'll approach that particular hair loss. So first and foremost, I don't think I can ever give or talk about hair loss without first talking about scarring alopecia. This is really important for you to rule out. It's similar to alopecia areata in that it is immune mediated, but this is an immune-mediated inflammatory infiltration of the hair follicles that leads to complete hair loss, obliteration, and scarring. Symptoms sometimes can include scalp pain, tenderness, itching, and the scalp can sometimes also appear erythematous and scaly. Sometimes scarring is clinically evident later in stages, and obviously it's of much importance to catch this early before this happens. And some examples include lichen planopilaris and discoid lupus. So once you've figured out that it's not a scarring hair loss, which we'll talk about at the very end, how to approach someone walking in with hair loss, we'll kind of drill into what is alopecia areata. Like I said, it's an autoimmune disease, and essentially it's a loss of immune privilege where your body is no longer, I'm not going to go into the specific biochemical pathways, but there's a loss of immune protection of those hair follicles that leads to a T lymphocyte-mediated attack on the hair follicles. It's the second most common type after pattern hair loss. It's a non-scarring hair loss type. It has an equal occurrence amongst genders. Most commonly, it onsets before age 20. And it certainly has a correlation with other autoimmune diseases like thyroid disease. So presentation, a patient's going to present with a round, patchy, well-circumscribed, smooth, complete hair loss. When you're looking at this kind of with your gross eye, I think we all know, but just to kind of go over the basics, you can have patchy alopecia areata that is diffuse, or perhaps it's only affecting one area. It can affect the scalp or other hair-bearing areas, including eyelashes. You can have alopecia totalis, which is complete loss of the hair of the scalp, and alopecia universalis, which is complete hair loss of the scalp and the rest of the body. You can also have other presentations or other manifestations, including pitting and ridging of the nail as well. But this is a much more severe disease. Next slide. One important skill that you can have as a dermatology provider is trichoscopy. This definitely requires skill and specific knowledge to be able to diagnose it, but it can be very helpful in helping distinguish between alopecia areata and a scarring hair loss, especially when the scarring hair loss is in its early presenting forms. So here, we can go back to the first slide, sorry. So in this first, these are all going to be dermoscopy images. And I think as with any dermatology topic, it helps to see lots of examples. This is an example of exclamation point hairs, and you'll see these most commonly in the periphery of an alopecia areata because that's where the autoimmune disease is most active. And it has a narrowed proximal end and a thickened distal end, and it looks like an exclamation. The next slide now. These are a sign that you'll see, and you'll see that they're just black dots. So it looks like just little black dots. And these are the follicular openings. And this is, again, really important because you can see that there is still follicular ostia present, which, again, is a distinguishing factor between a scarring hair loss and alopecia areata. Here, I know that maybe the arrows are a little bit small, but you can see here there are multiple examples of different presentations for alopecia areata. So first, we've got more examples of the black dots that are pointed out with the blue arrows. With the red arrows, we've got broken hairs. The green arrows point out exclamation point hairs. And then you've got occludability hairs pointed out by the purple arrows, which these are all great examples and help diagnose alopecia areata. So as with all diseases or all dermatologic diseases, a dermoscopy can be quite helpful, and that includes with the presentation of alopecia areata. All right, and then this is the last photo. So these are what are called yellow dots under dermoscopy, and these are hair follicles that have no particular hair shaft, but are filled with sebum. You can see this in androgenic alopecia as well, but they're going to be equally distributed in onset of or presentation of an alopecia areata versus an androgenic alopecia is going to be less evenly distributed amongst the area of hair loss. All right, so I wanted to set the baseline before we jumped in. And when we're talking about diagnosis, I couldn't not at least give some background and some dermoscopy images because I love looking at dermoscopy anytime I can get the chance. So we're going to jump in and talk about the diagnostic approach. So I'm going to be referencing the expert consensus recommendation articles for appropriate serological testing for the chief complaint of alopecia that was published in the JDPA. And so we really, as a group, focused on what labs we should be getting when we're approaching a patient with alopecia. So before we get started, and I think Dr. Mostaghimi will also be going over this a bit, but I just wanted to briefly touch on the E-Delphi method in case you weren't familiar with this. Step one, as with any research project, is defining the research question and objectives. And when we looked at the literature, there was certainly a gap when we as clinicians were trying to understand what serological testing we should be getting when a patient walks in the door with alopecia. Next, I recruited an expert panel, which on the next slide we'll get to in a minute. I'll give credit to those folks who we couldn't have completed the project successfully without. First, we did an extensive review of the literature, understanding what had been published on this topic, developed an initial questionnaire that included a list of statements that encompassed that literature, some of which were expert consensus driven, but the majority of them were driven by actual published clinical trials and other evidence. We distributed this questionnaire electronically to a variety of experts in our field across the US, including dermatologists, dermatology APPs, and also primary care APPs. They announced, or rather voted in that survey, gave feedback, and we were able to meet, analyze that feedback, conduct multiple rounds if needed, and then reach, obviously, at the end, a final consensus on how we should be approaching the diagnostic workup of alopecia. Next slide. So this is just a quick overview of the folks that were involved in the actual review of the literature and who had the great honor of publishing with. Next slide. So we're going to get into the workup recommendations. I think first and foremost, the big thing that we found in this study is that when you're approaching any patient with alopecia, it's really prudent to be, or really important to be prudent with your labs and really understand what you're ordering and why you're ordering it. Again, I kind of referenced this earlier, but I think in primary care, probably more so than dermatology, but also dermatology, we tend to over order. And I think this is really based on the fact that we are passed down in our training to say, well, we order that. And sometimes we don't push back and ask why we're ordering that, or is it going to benefit the patient in ordering that? And so when we looked at specifically alopecia areata, these were the specific tests that could potentially be beneficial, although with any piece of literature or any piece of science, I think there's a lot more work that could be done. But specifically zinc, TSH, thyroid antibodies, and vitamin D are, we can selectively use these labs to further work up the patient. Go to the next slide. So first, zinc. There was actually moderate evidence that zinc levels are lower in patients with alopecia areata. This was especially found in more severe or resistant cases of alopecia areata. And we did find, it was well supported that zinc definitely plays a biological role in the hair growth and also the immune regulation, which obviously is hugely important in alopecia areata. It's really important to note, though, that zinc deficiency was not an established primary cause of alopecia areata versus really it was correlated with the occurrence of alopecia areata. And even if you find a low zinc level in your patient, zinc supplementation isn't universally recommended unless deficiency is confirmed or strongly suspected. Next is the thyroid. I think this should probably come as no surprise because a lot of thyroid abnormalities can be autoimmune driven, as with Hashimoto's or Graves' disease. And so these two disease processes are likely linked through autoimmunity. And thyroid abnormalities are much more common in AA patients. But again, as with a lot of these, it's associative, not a causal relationship. And certainly selective screening is very important. But I think that, again, getting a good history, actually talking to the patient and figuring out, do they have other symptoms of hypothyroidism, such as constipation, and you're not just looking at, the principal presenting symptom of alopecia alone. Vitamin D deficiency was commonly observed in alopecia areata and may correlate with higher or greater disease severity. It likely does play a role, just like zinc, in the immune regulation and hair follicle cycling. And supplementation may help if deficiency is present. I joke with all my patients in Minnesota that everyone should be on vitamin D because we don't get a lot of sunlight, especially in the cold winters. If you're listening in from a more warm area of the country like Miami or maybe California, maybe you don't have to worry about as much vitamin D if you're getting outside with, of course, your sunscreen. But this is not a standalone treatment for alopecia areata, as Dr. Mostaghimi will get into. But certainly, I think it's very low risk to be supplementing something like a zinc and a vitamin D with a patient with alopecia areata, and it may prove to be helpful. So workup recommendations, I think it's really important to really outline what's not helpful in really alopecia overall, but also specifically alopecia areata. I know a lot of my family medicine colleagues, both physicians and advanced practice providers, often order a lot of these tests, and they're just not supported by literature. So androgen hormones, I know, are one that is ordered quite a bit. And these are usually normal or only mildly abnormal when it comes to alopecia areata and likely does not have a significant clinical relevance. Inflammatory markers, ANA, vitamin B12, uric acid, again, all of those perhaps can be helpful if you're looking at a specific other presenting factor besides just alopecia areata. For example, if you have a high suspicious for discoid lupus, meaning that you're looking at the patient, you're thinking that it's a hair loss, perhaps ANA would be helpful. But if you've tailored down your approach to, being a non-scarring hair loss, these labs are likely not to be helpful. So this is a full list of the consensus statements, and I certainly don't have to go through all of these, but the one thing I do want to point out, because I think it is important, is if we're seeing a scarring hair loss and we're not sure that it's alopecia areata, it's very important to do scalp biopsies, while this wasn't a serological workup, we as a research committee did feel it was really important to highlight this. And we specifically recommend 4 millimeter punch biopsies that should be submitted for vertical and horizontal processing by a dermatopathologist. Go to the next slide. So you certainly can look through these. We split it up by scarring and non-scarring alopecia. We can keep going through these. This is really for your reference, and we'll go to the flow chart here. But I really highlighted the key takeaways when it comes to alopecia areata specifically. This was a diagram. I think we're all advanced practitioners at this point if you're on this call. But this is a simple flow chart that you especially can remind yourself of as you're working through someone presenting with hair loss or alopecia. And certainly we should be sharing with our newer colleagues who are entering dermatology or in primary care who maybe perhaps aren't as familiar. But this is certainly a good approach. And I think the big point is when you're looking at the hair, the big distinguishing factor again is the follicular ostia. Are there follicular ostia present in the area of concern? And if the answer is no, then you're most likely dealing with a scarring alopecia. If the answer is yes, then a non-scarring alopecia. And then if it's a patchy loss and you're looking at like oval patches, this could be concerning for alopecia areata, or moth-eaten patches is more consistent with syphilis. And if the loss includes eyebrows, eyelashes with normal vellus hairs, you're thinking more of trichotillomania. And again, if you're, with alopecia areata, you can have more than just patchy or diffuse patchy presentation as well. And then, of course, there's the other presentations as well that I really don't have to go through. But this is a nice chart to really kind of get you on the right path as far as making the correct diagnosis. All right, so diagnostic recap. I think first and foremost, it's very, very important, even when you are 99% sure that someone's presenting with alopecia areata, that you first rule out a scarring alopecia. Especially in primary care, we have to do this very quickly because we have to either be able to do those biopsies or get that patient in the hands of an experienced dermatology clinician that can do that and do that in a more expedited way. If you've ruled that out and you suspect AA because they have round, patchy hair loss affecting the scalp, just remember that it can also affect other hair-bearing areas as well, such as the patient's beard area, the eyebrows, and it can also have other diagnostic features like nail pitting. Useful to use trichoscopy as a diagnostic aid. And if you want to order labs, I think it would be very reasonable to order a zinc, a TSH, thyroid antibodies, and or a vitamin D level. I think, again, these are low cost, relatively low cost labs. And if you do find abnormalities, it's just important to remember that there isn't significant literature to support that if you were to treat these, that they would significantly alter the course or prognosis of the alopecia areata. But I think certainly if you find an abnormal thyroid that needs to be corrected, that's very important, for non-dermatologic reasons as well. And I think it's very reasonable to supplement zinc and vitamin D as it's very low risk for the patient. All right, here's the references. And thank you so much for letting me talk to you tonight. I'll hand it over to Dr. Mostaghimi.
Thank you so much, Hayden, for your overview. And we'll go to the next slide. What I'm going to present is the combination National Alopecia Areata Foundation and American Hair Research Society Delphi consensus. And this is our treatment guidelines for adults with severe alopecia areata. So if you evaluated a patient and came to the conclusion of alopecia areata, just like Hayden told you to, now what do you do next? How do you figure out what the best treatment is for these patients? This is a rapidly evolving landscape, and we're really excited to be the first to take a stab at clarifying what you should do. I'm also excited to let you know that these results have just been accepted and are in press at JAMA Dermatology. Hopefully they'll be out in the next month or two. Next slide. Next slide, please. So the world of alopecia areata, we have 3 FDA-approved medications. They came 3 years in a row. There's a fourth one that is now registered for approval, hopefully next year. And this came after a whole lifetime where we had no treatments for alopecia areata. We've had a lot of scientific and clinical inquiry and a lot of investment and interest by industry. So it's a really exciting time. We're really in a golden age for this treatment. Next slide, please. So our goal really now is to make sure that every patient with alopecia areata who wants treatment has access to a safe and effective therapy. Next slide. And the main issue we have, the last mile, so to say, now that we have some of these treatments, is how do we make sure that patients and prescribers, the insurance companies and pharmaceuticals, how do we make sure that they're all aligned to ensure that patients get the treatments that they need? Next slide. So part of the answer for us is to create guidelines. And the key about guidelines, Hayden just presented some guidelines, but the key of guidelines are this is a collective analysis of data. And it's not just data, because data, if we had just had the answer, we would just say, here's the answer, right? But it's the data combined with clinical expertise to provide a roadmap for standardized treatment of patients. Next slide. So what guidelines are uniquely not is the right answer. So just because something is offered in a guideline, either Hayden's guidelines or these guidelines, it doesn't mean you shut off your brain and don't think about anything else. It means that this is a general ballpark you should be in. You should always use your clinical expertise. There's going to be exceptions or times where you want to do something differently. Listen to that. That's why you're there. It's not meant to be limiting of clinical choices. So really guidelines are about the standard and best way of doing something, but there's going to be exceptional cases where patients, maybe because of something about their disease, maybe something about their goals, maybe something about their other health challenges, benefits, etc., that they may go a different path. That's totally okay. This is just a starting place. And the last thing that guidelines are not are sort of etched in stone. These are temporary. So as we learn more about these drugs and more drugs come, the idea will be that hopefully we'll come back and update this. I'm inviting myself back to talk next time we update these. Next slide, please. So the objective of our study was to establish and create the first set of standardized treatment guidelines. And the key thing here is we're doing this for adults with severe alopecia areata. That's what I'm going to talk with. So this is not for kids. It's not for people with mild and moderate disease. We just don't have enough data to do those yet. We're hoping to do those studies, those consensus in the future once there's a little bit more information. Next slide. So we talked a little bit about what Adelphi is. Adelphi is really a fancy word of describing a process where you go through iterative rounds where everybody votes and they come to a general consensus around what the right answer is. It doesn't mean that everybody's in agreement. In order for something to be included in the Adelphi, it has to have over 70% agreement. For it to be excluded, it has to have 70% disagreement. And there's some things in the middle that we just don't have enough information for. Those are areas where we need to learn more to establish consensus. Next slide. So in order to do Adelphi, what we first did was we did a systematic review of all current and historic treatments for alopecia areata, and that was as fun as you can imagine it being, right? Tons of articles, a lot of really old stuff, a lot of low quality stuff, but we took 30 different treatments, we synthesized all of it, and we reviewed it. And then we presented that to people so they had all the information about all the treatments when they were deciding on what to vote for the guidelines. But our first step that we had to do after doing our research was to create a standardized definition of severity. Next slide. So for the results, we received consensus on the definition of severe alopecia areata. I'll present those in a moment, 90%. Treatment guidelines for adults with severe alopecia areata, 89%. And then a longitudinal management model. So what do you do after you've started? How do you keep on treating? So we'll go through all three of these right now. Next slide. So if you take one key thing from this talk, I want you really to focus on this slide. And this is defining severity for alopecia areata. So this is called the AASC, or Alopecia Areata Severity Score. We call it the ASC. And what it does is it itself was developed by a group of alopecia areata clinicians who really sought to take what we know as clinicians taking care of patients and combine that with quantitative measurements of hair loss to come up with a more holistic model of how we can measure severity for our patients. So in clinical trials, the severity of alopecia areata is only measured by something called the SALT score. The SALT score is a percentage of hair loss. So it's how much hair you're missing on your scalp. So if you have a SALT score of 100, it means you've lost all your hair. If you have a SALT score of 0, it means you've regrown your hair. So in the trials, they just drew the line in the middle. They said if you have above 50% SALT score, so you've lost over 50% of your scalp hair, you're considered severe. And if you grow back so that you've lost less than 20, or you've grown back over 80% of your hair, then you're considered a success in the trial. So you had to be over 50 to enter the trial, and below 20 to be considered a responder to the medication. This is a nice place to start, but really doesn't align with how we think about our patients. First, 50% hair loss is a lot of hair loss, right? I always ask, show me the patient with 48% hair loss who feels really good about their hair. And they're like, oh, thank goodness it wasn't 2% more than 50. This is not a categorical issue like that. People can feel bad regardless of how much hair they've lost. The second aspect is that it doesn't capture the psychosocial impact of the disease. As we know, alopecia areata is not a very physical ailment, and that patients don't have a lot of physical symptoms, although some people describe a little itching and burning and discomfort. The majority of the symptoms are psychosocial. And next, it doesn't think about any of the special parts of the body, right? It only looks at the scalp. So the AASC tries to adjust this by starting with the measurement of the disease severity. Severe disease is labeled as over 50% hair loss. Moderate disease is 21 to 49%, and 20 to below is mild hair loss. But the key thing that you can do here is increase by 1 point the level of severity, by one category, the level of severity, if one of four things are involved: eyebrow eyelash involvement, negative psychosocial outcomes, inadequate treatment after 6 months, or positive hair pull test. This is when you gently touch the hair next to an active lesion. You pull it gently, and if the hairs come out easily, that means the disease is active and there's a positive hair pull test. So if you have, let's say, 25% hair loss and you stop going to school, or you can't go out on a date, or your patient is really nervous at work and worried that everybody's looking at her because of that, that would be considered severe. And in my experience, while this, again, is not perfect, it aligns much more with how we think about and treat patients. And part of our guidelines is to push this idea that patients' severity is defined by more than just scalp hair loss. Next slide. So these are now getting to the results of the guidelines. So the primary treatment that we recommend for all patients with severe alopecia areata is JAK inhibitors, and specifically oral JAK inhibitors that are FDA approved for alopecia areata. Sometimes you may use a JAK inhibitor that's not FDA approved, such as tofacitinib, but given the amount of data and information about the efficacy and long-term safety of the FDA-approved medications, those should be the ones that you start with. Treatment should be long-term, uninterrupted, and continuous, with the same drug and the same dose as long as the patient achieves their goals and the treatment response is maintained. So non-medical switching of drugs. So if their insurance formulary changes and they happen to be on one drug and then the insurance wants them to switch it, you're going to show them this document and say, look, that's not appropriate, because we know that patients can lose hair when they switch, and that can be very challenging for them. All the JAK inhibitors are medications that you take on an ongoing basis. They're not medications that you stop or take here and there, and it really should be focused on making sure the patient has continuous coverage. Finally, if the treatment response with one JAK inhibitor is incomplete, other oral JAK inhibitors should be considered. And this is, I think, is a unique aspect of JAK inhibitors, not only for alopecia areata, but in general in dermatology and atopic dermatitis as well. And it's a little bit counterintuitive. If I had a patient who didn't do well on an IL-23 inhibitor, for psoriasis, I probably wouldn't switch them to another IL-23 inhibitor. I'd probably switch them to an IL-17 or something different. That's not the case in alopecia areata. Regardless of mechanism of action, there seems to be differences in metabolism or differences in behavior of these drugs in a way that we can't anticipate. Wherever you start one, you don't get to where you want, it's okay to switch to the next one. And that should be your standard and approach going into this. Next slide. For patients that have a significant atopic history, this could be asthma, it could be eczema, it could be nasal polyps. That's about a quarter of patients, about 15 to 25% of patients with alopecia areata. Dupilumab may be an option for them as well. Now, this data is not nearly as good as the data for JAK inhibitors, and dupilumab is not FDA approved. But it is safe. It will grow hair often in these patients and will often take a little bit longer, and maybe the hair doesn't grow as well. But there are definitely patients who will benefit from this. It doesn't seem to have efficacy in patients who do not have that atopic history or background. So I would consider this as an alternative to JAK inhibitors if patients are reluctant to take them. With patients with severe alopecia are reluctant to take JAK inhibitors, this could be an alternative if those patients also have an atopic history. Next slide, please. So in addition to JAK inhibitors as the mainstay of your treatment, there's other adjunctive treatments that you can add. I usually add these later if patients aren't responding in a way that I want. Some of my colleagues will add them earlier. So low-dose oral minoxidil is from 0.625 to really 2.5 for women and 2.5 to 5 for men, although some women can tolerate the 5 milligram dose. That's fine for any aspect of hair loss. Topical minoxidil works great for the face and scalp. You can't really apply it on the eyelashes or the eyes. It stings and gets into your eyes. Similarly, intralesional corticosteroids, I take a break from them, but if there are certain areas that are stubborn or not growing, either on the facial hair or on the scalp, they can be a reasonable adjunct. High potency topical steroids, I'm not a big fan of this, but the Delphi was, and using that on the scalp may be appropriate for some patients. It probably works better in kids than it does in adults. Oral corticosteroids are something that can be used to reduce severe and rapid hair loss. You really shouldn't be using these very long. When you start oral corticosteroids, imagine that you have a timer that goes off, and at 3 months, you really should be off of them. So they may be a bridging medication, particularly if you're waiting for prior authorization or things along those lines, but really shouldn't be a cornerstone of your treatment. Finally, topical prostaglandins like bimatoprost may help for some of the facial hair, and topical JAK inhibitors, which really don't work for the scalp, may have some benefit for facial hair, eyebrows, eyelashes, beard. Next slide, please. In addition to this, it's really important that not all patients want medical treatment. And for these patients, support to obtain cranial prostheses and camouflage is a wonderful option if that's what your patient wants, and he or she is excited by that. Mental health screening and support. So you really need to understand how this disease is impacting your patients and make sure that even if their hair is growing, the psychological impact, both during that process and also the fear of losing that hair again, can lead to PTSD-like symptoms that you really want to make sure that somebody is helping them with. So they can connect formally through a healthcare professional. They can talk casually to other people. You just really want to acknowledge this and make sure they're aware of that and that they get the help that they need. Finally, referral to patient advocacy organizations such as the National Alopecia Areata Foundation can really be a wonderful resource for patients. They can do a lot of peer mentorship. It's a source of good information. Some patients love it. Some patients want to be more casual and just look up information. It doesn't really matter. They can meet them wherever they are. Next slide, please. For longitudinal management, if you have been stable for about 6 months, if you're satisfactory, you continue that. If there's a partial response, you can increase the dose of the medication. If you're on a medication, let's say like baricitinib that has 2 doses, you can go to a higher dose, or you can adjust and add adjunctive therapies. If there's limited no response after 6 months, this is when you want to switch to another JAK inhibitor. But that 6 months is a minimum. If you see movement, 6 to 9 months is totally fine to wait. Some patients are just slow. Next slide. So this is all this information in one place here. So you can see again, primary treatment, oral JAK inhibitors, maybe dupilumab in some patients, cranial prosthetics, mental health screening, and patient advocacy organization referrals. And then those are a list of the adjunctive treatments as well. Next slide. One below. So one thing to notice is that what's not here is also important. The sun has set for some of these treatments. Methotrexate, cyclosporin, Cellset, mycophenolate, azathioprine, hydroxychloroquine. These are all things that I've tried. As I tell my students, when there's a long list, the longer the list of medications for a drug, the less they work, right? So some of these may work in some patients, and you may choose on edge cases to use them, but they shouldn't be your standard go-to. The risk benefit is not there. Things that we couldn't agree on were intramuscular corticosteroids, insulin and the other sensitizing agents, the role of PRP or antihistamines, or low-dose IL-2. These are areas that I think we need more information, and hopefully we'll come back to them in the future as there's more data. Next slide. So looking at our conclusions, next slide. The take-home points. Oral JAK inhibitors are the mainstay of treatment for adults with alopecia areata. Severe disease is decided by not just the SALT score, but a combination of SALT score and the actual impact it's having on the patient. For patients that have a history of ATP, dupilumab may be an alternative treatment, although JAK inhibitors are still preferred. Adjunctive therapies may be used to supplement response to the primary treatment, and patient coping resources are an important pillar of AA management. Next slide. So one of the key limitations here is that we don't have very good data in alopecia areata outside of the key pivotal trials for the new FDA-approved medications. It's possible that there's something that we're missing here. And this is really the subjective experience of the 30 people that were on the study. Next slide. In the future directions, we're hoping that this is a living resource. It should evolve. We want more high-quality data. And then look at who we need to go to next. Children, pregnant patients, a mild to moderate alopecia areata. We're hoping to chip away at these over the next few years. Next slide. Please let me know any questions in the chat. Hayden and I will go through them now. And thank you so much for listening.
Thank you so much for taking us through this We really appreciate the insights and the amount of work that you undertook to bring us these evidence-based guidelines and really showing us how these documents can be used to advocate for our patients to get the medicines that they need, to stay on the medicines that they need, so that they can have some relief. So thank you so much, both of you. And now I'm just going to turn to the chat. Please feel free, if you have questions, to put them in the chat. One that I was curious about, Dr. Mostaghimi, I do not think about switching, as you said, medicines in the same class. So what do you think is unique about the JAK inhibitors that allows us to do that?
So we don't know. This is an open question, and there's kind of two answers to this question. One is that the stated sort of like if something's a JAK1/2 blocker, something's a JAK3 tech blocker, how they behave in vitro when they're doing kind of the laboratory analyses to do those analyses, and how they behave in vivo is a little bit different. So everybody blocks things a little bit differently in the body than they do in the test tube. So there's slight variations, even though they may be labeled the same, in contrast to biologics, which are so precise that they kind of work the same for everybody. So that's one aspect. A second aspect may be that although patients with alopecia areata, look the same, the phenotypes are the same, it may be that the actual underlying inflammation is driven by different pathways in different folks. And depending on how you metabolize that JAK inhibitor, it may work better for one person and not for another. It becomes incredibly complicated. So I'm speculating here. And I also agree with you that it's counterintuitive. It doesn't necessarily make sense. But the best JAK inhibitor for your patient is the one that you can get, right? Is the one that insurance pays for and gets. And then we don't have that many options outside of JAK inhibitors now. Maybe in the future we'll have more choices, but if that JAK inhibitor doesn't work, it's totally reasonable. And hopefully someday I'll be able to answer your question more precisely to go to another one.
We have a question. What is the profile, would you say, of a patient that you would say is responding well to treatment?
So this is a wonderful question because we left this deliberately vague in here. We didn't want to define what a good treatment was or a good outcome was. So like a lot of things in alopecia areata, it really depends on the patient. So the two things I would ask, is the patient happy, or does it look like they're on the way toward being happy, right? So I'll give you an example of there are some patients, and we know this particularly from the baricitinib trial, that it takes almost 2+ years for them to grow back their hair. But if every time I see them, they're growing a little bit of hair, a little bit of hair, a little bit of hair, and I see they're going the right direction, even though they're not at target, that's somebody that I like to keep on that treatment and have them go, right? A second example might be, I have, for example, some African-American patients who are really happy with even 40 or 50% of their hair because all they want is to be able to style their hair in the way that they want with weaves or braids or other things that they want to attach to their hair. So the actual percentage that they need in order to achieve that is a lot less. In contrast, I have patients that have grown back 90% of their hair, but the hair they haven't grown back is a band right in the front or right along the part. And these patients aren't happy. And in that case, even though you're almost there numbers wise, you're technically a responder number wise, it's not achieving the goals that they want. So this is really, you have to connect with the patient, see where they're going, see what makes them happy, and then make those decisions together.
Yeah. I've been surprised when I've utilized these medicines for my patients in, really they can be non-responders early, but then that kind of 6 to 9 months, they can really start regrowing. So a lot of that, has that been your experience too? Or when do you start to see that kind of, if it's going to happen, it kind of happens?
So absolutely. So I really sandbag the estimates for my patients. I want them to stick on the drug. So right now is May, right? And if I saw a patient today, I did see a patient today. I started a patient on a JAK inhibitor for alopecia areata today. I told her, we're not going to make a decision about whether this drug may or may not be working for you until Thanksgiving, right? I always use a specific holiday. Thanksgiving seems impossibly far away. We're barely getting into summer, right? And the idea that Thanksgiving is, so we're going to start making a decision then, and we're not going to make a conclusion until 9 months, which would be Valentine's Day next year, right? So these are kind of the posts that I put. There's about 5% of patients who grow hair faster than you could ever imagine. They're hyper responders. You see this across all the drugs. And there's another about 30% of people that grow it in the time frame of the trial, so around about 3 to 6 months. And then there's another 30% that grow very, very slowly. These are the patients that may grow even up to 2 years, right? They go slow, slow, slow. And then across all these medications, there's about 1/3 to 1/4 of people that just don't respond to JAK inhibitors. We don't quite understand why that is, and they don't do well. So I agree with you that as long as you're beginning to see that movement and improvement, I usually give them at least 6 months before I really make a decision. If I'm not really moving the needle by 6 months at all, then that's when I start making a decision. If I'm starting to get velocity, then I stick with it through 9 months. It takes a lot of coaching, and you have to tell them up front, because you tell them at 6 months, it sounds like an excuse. If you tell them up front, it sounds like you're setting an expectation.
Right. Yeah. Allison says, thank you. This was very informative. She says, can you share how you educate patients on the potential cardiac side effects of the JAK inhibitors?
Yeah, so this is super important. And Allison, I do this pretty quickly with roughly the same script. So the most important part, I feel, is when I'm like who I'm picking, right? And although we focus on all these different challenges that patients have, when it comes to thrombosis and cardiac side effects, the majority of patients with alopecia areata are healthy folks, right? So you're looking at your major risk factors: obesity, being a female, being on oral contraceptive, a family history of clot, smoking, things along those lines. So things that I can adjust. Smoking and obesity is a really wonderful time to say, look, let's get you referred and get you stop smoking. Let's see if we can get you on these GLP-1s or have you meet with a nutritionist to adjust your weight. And if they're motivated, that's a wonderful thing. And I say, look, that helps you across your entire life, not just your hair, right? So those are wonderful things. And for the rest of it, if they have those other issues, I'll have a conversation with them, or maybe a conversation with their primary care doctor or cardiologist to have that. But in general, when I'm talking to patients, the majority of my patients are patients that have 1 or 0 risk factors, in which case, for me, it's a total green light. It's go. And what I say to them is the same way I talk about the black box warning in alopecia areata and for all the JAK inhibitors in general, whether it's for AD or for AA. And I say, look, these medications are associated with an increased risk of infection. They're associated with an increased risk of clot. There's a black box warning on all these. It also says you might get cancer. It also says you might even die from it. So you're going to say, hey, why is my doc crazy? Why is he putting me on this medication? The reality is that those elements on the box come from a different drug. They come from tofacitinib. They come at a higher dose, at twice the dose that we use now, at a time where we didn't know that wasn't that safe. And it comes in a different population, older patients with rheumatoid arthritis. So you are, I'll be like, you're a 30-year-old person and you're otherwise healthy and this is going well. There is a potential for these things to happen. You could get a clot, you could get an infection, you could get this. But the more we know about these medicines, and hundreds of thousands of patients have been treated over many, many years, the better we feel about their overall safety. We're going to watch you, make sure that it's okay, and we'll go from there. That's basically, you can't tell them, no, nothing bad is going to happen to you. It might, right? These are real things. They do happen to real people. But what you want to put it into context where it's not like you are trading your health in order to get your hair, right? If you have a 35-year-old woman, you don't want her to think, hey, I really want my hair, but I don't want to get lymphoma at age 45 and not be there for my kids. People think like that. They're not making those trade-offs. This is not the way these drugs work.
When Jennifer Winters says, some patients come to me with long-standing disease. Is there a duration of disease beyond which you're not expecting a response to these medicines?
So the earlier you treat, the better patients do. And the key part about defining that earlier, it means the duration of their current disease. So that doesn't mean, like, if I was 7 years old when I had alopecia, when I got alopecia areata, and then it went away, and then at 20 I lost all my hair, and it came back at 25, and then at 40 I lost my hair, and now I lost all of it. Now I'm 43. The duration is not from 43 to 7. It's only 3 years. It's that current time, how long you've been in that state. So this is something super different from the rest of our diseases, right? If somebody comes to me with psoriasis, psoriatic arthritis is different, but just psoriasis, and they say, hey, I'm not sure if I want to start a biologic. You're like, cool. Like, when you're ready, let me know. And if you start them 3 years from now, they'll do just as well as they would now. In alopecia areata, really at 4 years, it really starts diminishing the response. And by diminishing response, I mean both the level of depth, how well you grow your hair, and how fast you grow. That said, I will treat anybody with any duration of disease if they want with these JAK inhibitors, telling them, look, it may not work as well. It may take longer. We're going to figure it out. We're going to figure it out together, because although the response rate slows down and it goes down, right? The growth slows down and the response rate goes down. There are people who I've seen that was like 25 years of hair loss who grow their hair back. I mean, you don't know what's going to happen. So What I do, and this is a general tenet for hair loss, is that you partner with people for the journey, not with the promise of where they're going to get. And if they say, look, this is a journey, the journey might be rough, the journey may not get you to where you want to go, but there's a chance. I have no crystal ball. That's cool. They'll jump on top of that.
I have a follow-up question to kind of the two of you start someone on one and then we've talked about that we could switch to another, but if they're not responding, how long would you leave them on that first one before you switch them? Are you waiting 2 years or?
No, if they're not responding, I'm going like 6 months is really what I'm looking at. So 6 months is like, if I'm not seeing anything really, any movement at 6 months, I move on, right? If I'm beginning to see some movement or changes at 6 months, then I may check it and I may add something, a little, do a little injection, do a little minoxidil, something like that. If at 9 months, I'm not clearly seeing a consistent trend towards getting better, then I'm like, look, we're probably wasting our time here. Let's move on.
I thought it was very interesting, and so did the people in the chat about Dupy, because I have not heard that. And I'm curious, if someone is a non-responder or has failed or has a health contraindication, and you utilize Dupy, how long are you thinking before? What's the time length that you're thinking with Dupy?
So Dupy is like a 6 to 12 month medicine before you kind of see where it's going to go. It works a little bit more slowly. And then the depth of like to get to where you're ultimately going to end up is just slower to get there. So you'll see changes earlier. You'll see that growth, but you won't really know where they're going to end up for a while. And again, when it works only really in the patients who have that atopic history, right? So if you look at patients with that atopic history, you give them Dupixent, at least their atopy gets better, right? Their asthma gets better, their skin gets better. So they have some early wins, right? From that standpoint. They're happy to be on it because there's no lab monitoring and they're not worried about getting sick in the same way you are about JAK inhibitors. And if you get to the end of it and they didn't grow hair, you go back to the JAK inhibitor, you're like in the same place you were anyway, right? So the only person I'd be a little bit worried about would be somebody really coming up to that 4-year mark and you're like a little bit worried about the timing of it. But other than that, like it's worth a shot. Like if I was treating like my own daughter has alopecia, and if I was treating her, this would be something I would consider in her as a first line agent, just because although I'm very comfortable with JAK inhibitors, if I can be on long-term Dupixent, I'd feel better about that than being on long-term JAK inhibitors. I think that's pretty key. I don't think Cynthia, it would work. I've never seen it work in somebody for whom they failed a JAK that they respond to Dupy. So that's not the direction I would go ever. It's really for people as first line that you can try it.
Gotcha. Thank you for that clarification.
Yeah.
I was curious on your slide where you had the topical and you did not have topical JAK inhibitors used on the scalp. Can you talk a little bit more about the
safety of JAK inhibitors topically? So for patients that use topical ruxolitinib for AD patients, that's a great drug. It works really well. The safety of it comes from the fact that it is a large molecule and it doesn't absorb. And that's why you don't have to worry about blood monitoring and all these types of things, right? So that's awesome when we're doing skin-directed therapy. The challenge is that the inflammation in alopecia areata is deep below the skin. That JAK inhibitor just cannot get to where it matters there. So it just really doesn't work. That might be a little bit different for kids who have thinner skin. It might be a little bit different for your eyebrows, eyelashes, like face, where it's a little bit thinner. But it's not a great treatment.
I mean, I love the breadth and the depth of these explanations, because I think that's really elucidating for, people thinking about why we're doing and what we're doing. So please, if you have any other questions, feel free to drop them in the chat for us. And it was great to hear that these are going to be hopefully published in JAMA coming up.
That's right. So they just got accepted literally yesterday. So we're excited about that, and you'll be hearing. It'll be hopefully in the press and in the media, but you'll also have this that you can append to your letters to insurance, etc.
That's what I was thinking. That's what I was thinking is we can pop it right into those letters of medical necessity, and
that's right.
For our again, as we try to fight with to get these medicines for our patients.
Yeah,
I have heard, that you are on a dose, the dose is working. And then, so even if you have response, you shouldn't decrease that dose, right? You need to maintain that dose as you have said. You don't need to try to do you
It's
use that?
hard because JAK inhibitors are not really disease modifying. They're an ongoing treatment for alopecia areata. And the hard part about alopecia areata is that when you lose your hair, like you may lose, if I have shoulder length hair, you lose, a foot and a half of hair. And it takes 2.5 years for it to grow back, right? Flares are not like eczema where you get itchy for a few days and go back on the medication. There are some people for whom you do not need long-term treatment. The problem is we don't know who those people are, and many people will lose efficacy. So it's really worth a conversation. At the beginning, everybody wants to know when they're going to come off. And then later when they grow their hair, maybe in my experience, 1 out of 5, 1 out of 6 patients maximum may be interested in trying to come off, but it's really hard to do.
I am curious as well. There are some diseases that we deal with, pemphigus, different things, where we think about hardening, where we think about people becoming resistant because of drug exposure. Do you have any senses that alopecia areata is reacting like that, or that the response of these medicines will kind of work and then stop working? Any
I hope that's not
feedback?
the case. The
Yeah.
data right now across all JAK inhibitors suggests that if you do respond, maintenance of response is pretty high. Not as high as like a biologic, or not as high as like IL-23 inhibitors, where it's like 90, 5, 8, 90, like that. You do retain response. There are some people who just lose hair and we don't know why. That might be different, Cynthia, when we have more targeted therapies. Maybe there'll be like escape and things like that. JAK inhibitors are broad enough that I'm hoping we don't see that.
We have a question from Peggy here. If a patient says they did develop a condition such as cancer, cardiovascular, life-threatening condition, comes to you later and says, you did this, how do we respond or deal with this? If you documented, is that enough to protect you if they choose to pursue legal action? I don't know if we can wear this hat of medical legal, but I mean, do you have a
Yeah, we can try.
response?
So the reality is that I guess anybody can sue or say what they want to say, right? But your combination of counseling and documentation should be appropriate for that patient. So, my goal is not to force people to do anything or convince them. That's not my goal. My goal is to give people the options, engage in shared decision making, and help them make those choices. I actually think the APP community is better at connecting with patients and has more time often with their patients, and they're just a little more down to earth and accessible than a lot of doctors are to engage in shared decision making together. So if you do that right, where you're like, look, I'm just trying to give you your options, and this is a choice, and you have to decide whether or not you make that leap or not. And of course, you document that decision making. Anybody can say or do anything. They may be angry or what have you. Hopefully, you have to trust that the system will work its way out. That's the same for all, I think, any medicine that we use, any excision, anything we do,
Yeah, anything we do. But I think you make the great point there about the documentation and matching what you're doing with the patient. You're having shared decision making, you're sharing with the patient these warnings. So Peggy, thanks for your question. Good point there. Angela says, Hayden, will there be a follow-up to the SDPA hair loss clinical practice guidelines? And if so, what will be the focus?
Yeah, thanks for the question. It's so great to get all these answers from you, Dr. Mostaghimi. These are great, and I've learned a lot on this call as well. And as you can see, there are certain areas that I think our practice guidelines don't need to cover because other experts across the country are covering them. So alopecia areata was one of those areas of hair loss that we didn't feel that we needed to go into next. One project that we've already completed that'll be coming out, I think, somewhat soon. I'm not sure if it's going to be in the next issue or the issue after that, is telogen effluvium treatment approach. And so we have a group of clinicians, primarily from Mayo Clinic and some other areas of the country, where we got together and looked at treatment, our best treatment approach to treatment for kind of acute and chronic TE. So you can be on the lookout for that. Also underway is a nutritional expert consensus project where we're looking at kind of across the board nutritional deficiencies and how they manifest on a dermatological level. And obviously alopecia is one of those manifestations. So we're actually digging into those nutritional deficiencies a little bit more. So more to come.
Yeah, clinical manifestations of the nutritional deficiencies. Definitely. So thanks so much, both of you. We really appreciate your time. Thank you so much for everyone that attended. And thank you so much to AbbVie for sponsoring this discussion. Again, thank you for joining us, and thanks for all this information. The patients are really at the center of everything that we do, and we're so glad to be able to have these new amazing medicines. I agree with Dr. Mostaghimi. It is 15 years in practice, and I do feel like for the first time, we have some amazing treatments that we can put these patients on that they really can have some great clinical response. Hannah and Peggy echo me in the comments saying thank you so much to our very esteemed presenters. So thanks so much for joining us and being with us, and have a great night.
We appreciate it. Thank you.